The last video we finished up our common skin disorders, pretty much got through the first big section of dermatology. Now we're looking at vascular tumors of the skin. A lot of these tend to show up as part of a subsection of another question. So usually you'll have a question that's focused on around something else, and then they'll kind of transition to one of these things, or they'll mention one of these things, but the real focus of the question is something else. So you really need to know what the associations are rather than just knowing what these lesions look like or how they occur. You kind of just need to know everything basically, right? So there aren't too many of them, and I have some nice ways of memorizing most of them, so let's talk about that. First thing we have here is your notorious angiosarcoma, which from the name you can kind of tell angio has to do with blood vessels, and sarcoma is because it's malignant, right? So they tell you it's a rare blood vessel malignancy, typically occurring in the head, neck, and breast areas, usually in elderly on sun-exposed areas, associated with radiation therapy and chronic post-mastectomy lymphedema. Hepatic angiosarcomas are associated with vinyl chloride and arsenic exposures, very aggressive and difficult to resect due to delay in diagnosis. So we saw the hepatic angiosarcoma when we were looking at GIT earlier. And now that we're here at dermatology section, we're thinking more along the lines of the ones that are occurring on the head, neck, and breast areas. UWorld had a question where they talked about a woman who had gotten a mastectomy, and she kept getting chronic mastectomy lymphedema. And then she was, having issues in the question as you go on, and the answer was that she would have an angiosarcoma. So just make sure you can associate those things, right? Anyone with radiation therapy or chronic post-mastectomy lymphedema, and then the hepatic angiosarcoma with the vinyl chloride and arsenic. All right, vinyl chloride and arsenic. We've talked about vinyl chloride and arsenic a lot of times, especially when we were in pathology earlier, where we were looking at all the different things and the cancers they're associated with. You need to know that list very, very well, because that kind of stuff usually gives away a diagnosis. So if a question does mention arsenic, you can go ahead and just pick angiosarcoma. Same thing for vinyl chloride. Up here, we're looking at pictures of what angiosarcoma kind of looks like, because they didn't give any pictures for angiosarcoma. So on the left, we have a guy, look at this, he started in December 2014, then by February 2015, this is what's becoming of it. Yeah, so you can see how it's like kind of just covering the entire scalp. It's also on his left cheek, right? This one over here, you can see it's on both sides of the face, also going over the right eye. And you can see there's like this crazy amount of swelling under the right eye. So they tell you that the chemotherapy of choice for angiosarcoma has been a combination of Mesna, doxorubicin, and ifosfamide, in case you have to pick an answer for how to treat it. If they give you just a picture in any question, and I guess NBME is notorious for just giving you a picture and no more information, try not to get confused and think, it's not reactivated varicella zoster, right? It's not herpes zoster, because oftentimes it could look like it's only on one side, right? It's only on half the face, but it's not. It's actually going to be on both sides. And the question should mention something about either radiation therapy or exposure to one of these other things. The next thing here is bacillary angiomatosis. Again, angiomatosis, so you know it has something to do with blood vessels. And this disease itself is kind of directly related to Bartonella. We've talked about it earlier when we were in microbiology. So this is how it looks like, all right, and it can have many different images for it. Benign capillary skin papules found in AIDS patients caused by Bartonella infections, frequently mistaken for Kaposi sarcoma, but this is not a Kaposi sarcoma because it's going to have neutrophilic infiltrates in it. Right, so you'll know if you were to do a biopsy, you would see it would have high amounts of neutrophils in it because it's related to Bartonella. This will not occur in someone who has a good immune system, all right? Oftentimes people say it looks like a tomato, especially in this picture specifically. It does look like a tomato, right? It's a very tomato type of lesion. It's going to be pretty big and very, very vascular, right? So the name gives that away, and it's not too hard to get that down. In the immunocompetent, it has a different result. So let's take a look at that. We'll go back to Bartonella. So right here, we can see Bartonella is a zoonotic bacteria, usually related to cats, right? Getting a cat scratch. And the sketchy micro image right here has the thing. So this guy on the right with the cane, the cane is always a symbol of immunocompromise, right? So he's the AIDS patient, and his hat, as well as the little dots all over his body, kind of resemble the bacillary angiomatosis that he's going to get. Whereas she doesn't have that, right? So her issue is going to be completely different. On the immunocompetent, it just causes cat scratch disease, while bacillary angiomatosis occurs in immunocompromised. And the cat scratch disease, right, is just because she has a scratch on her right hand right here. It's just going to have non-caseating granulomas with stellate microabscesses and neutrophils, right? So axillary lymphadenitis, and that's why her dress has all the scruffs around the axilla right there. So very big difference between what it does in one patient and what it does in another immunocompromised patient, such as an AIDS patient. Cherry hemangioma versus strawberry hemangioma is a pretty big deal. These are usually like giveaway questions that you will not get right if you don't remember the specific thing. Clearly, you could tell they do look very similar. So B, and then for strawberry is E. Right, so they do look very similar, but the strawberry one is a little bigger, as you would think a strawberry is bigger too. There's a way to remember this, which one occurs in which, and I'm going to show you that. First things first, cherry hemangioma. It's a benign capillary hemangioma commonly occurring in middle-aged adults, and this one does not regress, right? And the frequency of this is going to increase with age, so they can have more than one. Whereas E, strawberry hemangioma, is a benign capillary hemangioma of infancy. So they're the same thing. They're both benign capillary hemangiomas, but there's a huge age discrepancy. Right? So cherry hemangioma is in middle-aged adults. Strawberry is in infancy. Appears in the first few weeks of life, grows rapidly, and then regresses spontaneously. And this is a pretty annoying question on UWorld, where they ask you, like, oh, okay, so you see this, you identify it, and now what are you going to tell the parents? And there was one answer choice that said it'll go away spontaneously, and there was another answer choice that said it'll grow, then it'll go away spontaneously, and you had to pick that. Right? So that was a little thing that UWorld did to make sure you remember this, and the way to actually remember it is to think of this person. Now, if you don't know who this is, the doll on the left is your strawberry shortcake from a cartoon. I said she is strawberry shortcake. Let her remind you that strawberry hemangiomas occur on babies, right? Because it's a doll. In addition, Cherry as an adult should remind you that cherry hemangiomas occur in adults. Furthermore, adults do not change. Should remind you that cherry hemangiomas will not self-resolve or regress. All right, so very simple thing that I made up when I was studying, and it's pretty helpful. You're not going to lose it. So you can see here in this one, right, this right one is a cherry hemangioma. It's clearly older person's skin, and they have more than one. Right, so the frequency of it increases as they age. This one in the middle is an infant. It's a baby's butt, and this is a strawberry hemangioma in the baby. Right, strawberry shortcake for the baby, cherry for the adult. Right, and the whole popping your cherry and adults do not change are ways to remember that this is not going to go away. That's going to stay there, and they're going to get more. Okay, this thing on the far left over here, this is your Kaposi sarcoma. Right, which is for comparison with the bacillary angiomatosis. Right, so clearly Kaposi sarcoma has quite a difference from image A. It doesn't look the same. And here you can also see there's plenty of them, depending on the severity of the Kaposi sarcoma. So Kaposi sarcoma is mentioned here too. They didn't give any images for it, so that's why I put this one here. Right, so Kaposi sarcoma is an endothelial malignancy, most commonly affecting the skin, mouth, GIT, respiratory tract, classically seen in older Eastern European males, patients with AIDS, and organ transplant patients, associated with HHV8 and HIV. HHV8, though, is the one that you'll directly get a question about regarding Kaposi sarcoma. Rarely mistaken for bacillary angiomatosis, but the Kaposi sarcoma, would have lymphocytic infiltrate. Right, so the real difference in terms of confirming one over the other would be the neutrophils for Bartonella in an AIDS patient with bacillary angiomatosis, and lymphocytic infiltrate in Kaposi sarcoma in either an AIDS patient or someone with HHV8 or HIV, any of that stuff. All right. They also come from different places, and for the most part, so this is an endothelial malignancy. Bacillary angiomatosis is just going to be a benign capillary thing. It's not malignant. But the bigger issue is, although benign capillary, skin papule, although this thing itself is not malignant, the fact that you have it means that you probably have AIDS. So it doesn't matter, right? So its presence in itself is a pretty grave issue. The last two, so this one here, a glomus tumor. This is again something that NBME would like to pick on, right? So benign, painful, red-blue tumor, commonly under the fingernail, as they show you right here, arises from modified smooth muscle cells of the thermoregulatory glomus body. The role of the glomus body is to shunt blood away from the skin surface in cold temperatures to prevent heat loss, or do the opposite when it's actually hot out. All right. So that glomus body is what actually kind of makes your fingers feel cold when it's actually cold outside, because you kind of make all the blood leave your extremities. Otherwise, if there's a lot of blood at your extremities, you're going to lose your own body heat. The last one here is your pyogenic granuloma. Never ever seen this anywhere, not in UWorld, not really in NBMEs that I've looked at. I'm not sure how this is ever going to present as a question. But this is a polypoid lobulated capillary hemangioma, so it's very different from the others. All right, very different from the others. You can see it's in terms of pictures, all of these are very different from each other. But if you look up more images of pyogenic granuloma, they're all lobulated, so that's a really big deal. They have lobules to it, and it's just sticking out so much more than the others. The others are pretty flat. The pyogenic granuloma is sticking out of the body pretty dominantly. And it can ulcerate and bleed, which is not pretty common for the other guys. The other guys, they can bleed also, but they don't tend to ulcerate. Associated with trauma and pregnancy. So if anything, you would get a question. If I was to be writing this NBME question on a pyogenic granuloma, I would probably start the question about someone who's pregnant. Everything's going fine with the pregnancy, and then all of a sudden this woman has some kind of weird, I wouldn't call it a pimple, I guess. I'm not sure what the term I would use would be. And either they would give you a picture and then they'll go ahead and tell you, or they'll go ahead and tell you that she's got some kind of outgrowth on her face and it tends to ulcerate and bleed. You have to be able to pick pyogenic granuloma. Really hard to get away with anything from this name though. This name doesn't really tell you much, so just be ready, I guess. Alright, and then we did angiosarcoma. This was a really big deal. In fact, of all of these, in terms of which ones are going to be high yield and which ones are most likely going to show up, angiosarcoma is very high yield. Right, bacillary angiomatosis and Kaposi sarcoma, their comparison is very high yield. And then cherry hemangioma versus strawberry hemangioma, their comparison is very high yield. So make sure you understand that. Right, and the strawberry shortcake thing should really help you remember that strawberries occur on infants. Cherry is popping your cherry as an adult, which means having sex for the first time, and that's going to happen in grown-ups, middle-aged people. So let's take a look at this angiosarcoma question from UWorld. So this one says, a 54-year-old woman comes to the physician because of multiple firm violaceous nodules on her right upper arm. She was diagnosed with right-sided breast carcinoma 12 years ago and was treated with radical mastectomy. Extensive axillary lymph node dissection performed at that time revealed no lymph node metastases. Post-operatively, the patient developed chronic lymphedema involving her right arm. What is the most likely etiology of her current skin lesions, which are the multiple form violaceous nodules on her right upper arm? So this is all occurring in the same area where she got the mastectomy, and that, in this UWorld question especially, they've used chronic lymphedema as a phrase. They won't necessarily do that on step 1 or an NBME question, but the chronic lymphedema should help you remember angiosarcoma, right? Chronic post-mastectomy lymphedema. So it was just an angiosarcoma. Chronic lymphedema is a risk factor for cutaneous angiosarcoma, also known as Stewart-Travis syndrome. Radical mastectomy with axillary lymph node dissection is a classic predisposing procedure, although any form of chronic lymphedema can be implicated. Histopathologically, angiosarcoma will show infiltration of the dermis with slit-like abnormal vascular spaces. The prognosis for patients with angiosarcoma is poor because the tumor is usually widespread by the time of diagnosis. There is controversy regarding use of the term angiosarcoma versus lymph angiosarcoma, as it appears that this entity arises from blood vessels and not lymph vessels. Alright, but either way, whatever it is, if you have a question scenario like this one right here, be ready to pick angiosarcoma. And look at the way they described it, right? Multiple firm violaceous nodules on her right upper arm. The one that occurs on the head and stuff looks very different from that, right? These are not multiple firm violaceous nodules. Right? So the one that occurs on the head, neck, and breast areas, the head and neck ones are very different from the one that's occurring in her axillary area due to chronic post-mastectomy. Also very different from the hepatic angiosarcoma. The hepatic angiosarcoma had a very unique thing to it too. Let me see if I can actually find that. I'm not sure. GIT. Yeah. See, so when we were here, we saw angiosarcoma, malignant tumor of endothelial origin associated with exposure to arsenic and vinyl chloride. And right after it, we saw another thing called the cavernous hemangioma, which was very unique, right? And we saw that this can usually occur in the liver, but then we had this Euro question down here where it was occurring. Where was it in this patient? In his brain, right? Yeah, in brain tissue. So all of these things, although they have a high yield area where they can occur in different places as well. Okay, so just make sure you remember the angiosarcoma thing and the fact that it can occur in multiple places. It's usually a giveaway question, just based off of memory. So arsenic and vinyl chloride for the hepatic angiosarcoma. Otherwise, if it's on the skin somewhere, then you remember dermatology and just try to see if you can find any other supporting evidence. Now, the next page goes on to talk about skin infections. A lot of these words were all used when we were going through our microbiology chapter, right? So if any of these words didn't make sense to you at that time, you should have probably either searched it up on Google or come here to look at it. Now, looking at these words here should ring a bell for a lot of microbiology stuff. So this video would be a good opportunity to go back to those things, those relevant things in microbiology, right? Throughout this entire playlist, I always mention a good day to review certain things because repetition is so key. So since we're here right now, a page full of microbiology things, make sure you go back and look at things under microbiology that is relevant here if you forgot it. So bacterial infections versus viral infections. The bacterial infections cause these things. So there really shouldn't be a time where you're using one of these words to talk about a viral infection. And if you have a question where they mention these words, that should also be a giveaway for not picking any answer choice that is a virus. All right. So impetigo, very superficial skin infection, usually from Ascaris or Aspergillus, highly contagious, honey-colored crusting. Bullous impetigo has bullae and is usually caused by Ascaris as well. So look at A and B. Right, so A is your crusty impetigo. This is your bullous impetigo, which is S. aureus. Right, so bullous basically means that there is liquid under there. Right, so there's some liquid under. Some of these are going to be vesicles that you can kind of rupture. Erysipelas is usually going to be Aspergillus, so it's an infection involving the upper dermis and superficial lymphatics, usually from Pyogenes. Presents with well-defined raised demarcation between the infected and normal skin. Right, very clear borders. It's very evident what's happening here. Very different from these two guys. All right. Now here and here, there's some kind of similarity. You can see this is also kind of bordered off. So what is D? You should be able to identify what D is just from the picture and where it was. That was cellulitis, right? So acute, painful, spreading infection of deeper dermis and subcutaneous tissues, usually from Pyogenes or Ascaris. Often starts with a break in the skin from trauma or another infection, right? Cellulitis. You just start antibiotics and this will start fixing up as well. So there is some overlap between these two guys, okay? This last one, what's that with the little thing on his middle finger? That is an abscess, right? Collection of pus from a walled-off infection within deeper layers of skin. Offending organism is almost always S. aureus, right? So that's your little abscess on the finger right there. Okay, this can just be ripped off and you can squeeze the abscess and you can get all the pus that comes out of it. Image F, look at this. Now this is starting to look real bad. It's starting to turn black now, right? There's like blood and the blood is getting oxygenated. That is your necrotizing fasciitis, which is another thing we saw with one of the darker cookies in the sketchy microimage for Aspergillus. This is a deeper tissue injury, usually from anaerobic bacteria or Aspergillus. Pain may be out of proportion to exam findings, results in crepitus from methane and CO2 production, flesh-eating bacteria, causes bullae and skin necrosis, violaceous color of bullae surrounding the skin, and this is a surgical emergency. Right? You need to fix this up as soon as you can. You need to do aggressive antibiotic therapy and just make sure that this doesn't get any worse because the patient is in a lot of pain at this point, right? And some of this is no longer reversible. Now G is also very common. You get to see this a lot if you're planning on doing pediatrics. These guys up here, even the cellulitis, all of these can actually occur. Not the necrotizing fasciitis so much, but these other ones up here, A through E and the G and even age are all things that you can possibly see if you do your pediatrics residency, if that's anything any of you are looking to get into. So G is your staphylococcal scalded skin syndrome, right? So the exotoxin destroys keratinocyte attachments in the stratum granulosum only, right? So that's comparing it to 10, which is toxic epidermal necrolysis, which destroys the epidermal dermal junction. And these are both actually diseases or conditions that I kind of talked about a lot when we did our microbiology chapter. Characterized by fever and generalized erythematous rash with slowing of the upper layers of the epidermis that heals completely. There is a positive Nikolsky sign, which always means that there will be separation of epidermis from just basic stroking. So you can literally just rub skin off like that. Commonly seen in newborns and children or adults with renal insufficiency. Alright, so that's your scalded skin syndrome. Now the rest of these images, the last three over here, these are for viral things, right? Viral infections. First one we have is herpes. We talked about HSV1 and HSV2 a lot when we were doing microbiology viruses. Herpes virus infections of skin can occur anywhere from the mucosal surfaces to normal skin. These include herpes labialis, herpes genitalis, and herpetic whitlow, which is on the finger. Alright, so herpetic whitlow. I is showing you molluscum contagiosum. Alright, umbilicated papules caused by pox virus. While frequently seen in children, it can be sexually transmitted in adults. Alright, so molluscum contagiosum. This is very rarely used as a phrase. No one ever really tends to use this phrase very much, so it can definitely be an answer choice for you. Be ready for that. Varicella zoster virus, we know what this does. We've seen it. It causes chickenpox and zoster, which are shingles, reactivation. Varicella presents with multiple crops of lesions in various stages, from vesicles to crusts. Zoster is a reactivation of the virus in dermatoma distribution, so it's only going to be on one side unless it's disseminated, but reactivation is almost never really disseminated. The last thing, hairy leukoplakia, which you have to compare to two other conditions. Hairy leukoplakia, which you can see here very, very barely. There's some white stuff on the side of his tongue right here. Irregular white, painless plaques on the lateral tongue that cannot be scraped off. Right, this is due to Epstein-Barr virus and is pretty much occurring because you have HIV. Right, so it occurs in HIV-positive patients or organ transplant recipients. Right, it's a sign of immunocompromise. Immunocompetent people will not have something like this occurring from Epstein-Barr virus. You're supposed to compare this to oral thrush, which is due to candida, usually in patients who are using oral corticosteroids, or leukoplakia, which is precancerous. Right? Leukoplakia on the inner cheek, precancerous. All of these kind of look very similar to each other. The candida one, which is oral thrush, that goes away from just, you're supposed to be swishing your mouth pretty often. And some of these can be scraped off, but the hairy leukoplakia here, due to Epstein-Barr virus, this cannot be scraped off. You can't get it off. All right. Next page talks about two extremely high-yield topics that you really need to know inside out. This is another comparison, very similar to how we did osteoarthritis versus rheumatoid arthritis, Crohn's disease versus ulcerative colitis. Now we're looking at pemphigus vulgaris versus bullous pemphigoid, which are very similar because they affect the same kind of thing. They both affect skin, basically, but are due to completely different antibodies. Pemphigus vulgaris is vulgar. It's the one that I say is worse than bullous pemphigoid, right? Potentially fatal, which already gives it away, right? Potentially fatal. So this is really bad. Most commonly seen in older adults, type 2 hypersensitivity reaction. You'll have IgG antibodies against desmoglein 1 and or desmoglein 3, which are all actually components of desmosomes. The first thing we talked about in the video before this, where we were looking at introduction to dermatology. Desmosomes connect keratinocytes in the stratum spinosum, right? Desmosomes are what connect its neighboring cells to each other. So if you have pemphigus vulgaris, you lose the connection between neighboring cells and the cells start falling apart. Gross morphology, you're going to see flaccid intraepidermal bullae caused by acantholysis. Right, so acantholysis was the word that meant separation of keratinocytes, and you notice a row of tombstones on H&E stain. I'm going to show you a good picture of that. Oral mucosa is always involved. Right? So remember when we were doing Crohn's versus ulcerative colitis, there were things that were always involved, things that are never involved, etc. You need to know those things, right? And then again, you have a positive Nikolsky sign, which is a big deal here because you do not have the Nikolsky sign in bullous pemphigoid. So you can see the positive Nikolsky sign right here, right? Just rubbing off skin and there's bleeding. All right, so skin can just be rubbed off. Reticular pattern on immunofluorescence, you see a reticular pattern around the epidermal cells. All right, so what is this row of tombstones? So row of tombstones on H&E stain. So I have a bunch of pictures here. This one here on the top, there's the top one and the bottom, right? So this one over here is pemphigus vulgaris. You can note the intraepidermal cleavage, acantholysis, and tombstone cells along the basal layer. So you can see what's happening here. It's not detaching from the basal layer. It's not detaching from the entire bottom portion. There's ripping of cells in between, right? And then if I was to zoom in, let's right here. So what they're referring to as tombstones are these guys right here. These are our tombstones on the bottom layer. They all look like tombstones, right? So you have your tombstones that are showing up on H&E stain. On the bottom though, this one you can see the entire bottom layer kind of separated from the top. Right, so this is bullous pemphigoid. Note subepidermal cleavage and no acantholysis. Immunofluorescence reveals linear IgG at the base of membrane. So here what you notice is basically the dermis separated from the epidermis separated from the dermis. Right, completely separated, and the whole thing is just on its own now. Because in bullous pemphigoid, you attack hemidesmosomes, which are actually the guys that connect the two of these together. Alright, so let's take a look at that. Bullous pemphigoid, less severe than pemphigus vulgaris, most commonly seen in older adults. It's also a type 2 hypersensitivity reaction, antigen and antibody. IgG antibodies against hemidesmosomes, which are epidermal basement membrane. Antibodies are below the epidermis, or below the epidermis. So here what you notice is that you're going to have a division of the epidermis and dermis. You're just going to lose that. So when it picks up, there's space in between, it fills up with fluid. So you end up getting tense blisters. You see? All of these are tense blisters. It's full of fluid containing eosinophils. Oral mucosa is going to be spared here, and it's Nikolsky negative. You can't rip off the skin. Right here, the connection between cells was kind of broken apart, so you could just rip cells apart from each other. But in the bullous pemphigoid, your skin layer is kind of coming off of your layer under that, so there's just fluid accumulating in between. And you have to remember it contains eosinophils. That's another thing you can get tested on. Right, so you got a linear pattern at the epidermal-dermal junction when you do immunofluorescence, because that's where all the antibodies are. Right, all the antibodies are right there. And they're all cutting it up, so it's separating. Okay? So that's generally it for that. Let me see. I think, yeah. So if you ever get a question on pemphigus vulgaris versus bullous pemphigoid, giveaway topics between one over the other is the placement of the immunofluorescence. Do you see it at the epidermal-dermal junction? Are you losing the epidermal-dermal junction and then fluid is accumulating under there with the eosinophils? Is the oral mucosa involved? Is the Nikolsky sign there? You know, those are things you're going to be looking for in a question, and based off of that, you should be able to pick an answer. Okay, so now the other half of this page are talking about other blistering skin disorders. You have your dermatitis herpetiformis, erythema multiforme, and Stevens-Johnson syndrome, which you have to compare with 10, the toxic epidermal necrolysis. Remember on the last page we saw staphylococcal scaldy skin syndrome, right, where you have exotoxin destroying keratinocyte attachments in the stratum granulosum only. But in toxic epidermal necrolysis, you kind of destroy the epidermal-dermal junction, very similar to bullous pemphigoid. Right, so make sure you're studying very actively. Always go back to things when they're related to stuff. A reticular pattern is like a net-like pattern. Right, so you can kind of see that between image B and D. Right, so reticular, this does look like you threw out a fishnet, and that's because you're kind of attacking all these spots in between cells. Right, so that's where they're finding antibodies, in between cells. Whereas this is a linear immunofluorescence, because all the antibodies are in one straight line, which is this line right here again, which is the dermal-epidermal junction. Right, so that's the main difference between the immunofluorescence. Alright, so we've seen dermatitis herpetiformis before, actually. Right, when we were in GIT, we talked about celiac. That had, you see, they tell you here, associated with celiac disease. Right, so in celiac disease, we saw dermatitis herpetiformis because a lot of the antibodies were shared. So what do you see in dermatitis herpetiformis? You see pruritic papules, vesicles, and bullae, often found on the extensor surfaces, right? So elbows, knees, buttocks, deposits of IgA at the tips of dermal papillae, associated with celiac disease, and treatment is using dapsone and a gluten-free diet if they have celiac. Now, dapsone was not mentioned in GIT, right? And we've only really seen dapsone being mentioned when we talk about in microbiology, the one disease that had to do with an armadillo. Mycobacterium leprae, where is it? What did I do? Oh, sorry. Clicked on the wrong thing. Right? Mycobacterium leprae, leprosy, which causes Hansen disease. This is the one place where we saw that you had to use for treatment dapsone. Right? Treatment dapsone and rifampin for the tuberculoid form, which was the Th1, and clofazimine is added for the lepromatous form, which was a little worse. Right? Lepromatous can be lethal. So dapsone really is not that commonly used, but we can see here that they tell you for dermatitis herpetiformis you can actually give dapsone. So be ready with that, right? You can get a silly question on that. Just be ready with that. Next one, erythema multiforme. So this is associated with infections. You can see it right here, right? So it's got this like target lesion kind of thing happening, right? You can see that with Mycoplasma pneumoniae. You can see with HSV. You can even see with a lot of drugs like sulfa drugs, beta-lactams, and phenytoin. It presents with multiple types of lesions: macules, papules, vesicles, target lesions, and it looks like targets with multiple rings and a dusky center. The center is usually going to have like some kind of crusting thing happening, showing epithelial disruption. Right. So up here I have another picture. This one is also erythema multiforme. So I always think of it as erythema with multiple rings, right? Multiple rings. You can kind of see the rings that are forming here too, right? You can see this one is like a really good ring. That's a really good ring. A lot of rings. Okay, so that's erythema multiforme, and you can get this in almost any kind of question, really. Just make sure you understand it's just a blistering skin disorder. It's not a sign of cancer or something weird like that. The last one and the worst of all of them is Stevens-Johnson syndrome, which is usually a side effect of some medication. Characterized by fever, bullae formation, and necrosis, you get slowing of skin at the dermal-epidermal junction with the positive Nikolsky sign. Right, so the slowing of skin at the dermal-epidermal junction, that kind of mimics bullous pemphigoid, but there is a positive Nikolsky sign, so you know it's not bullous pemphigoid, because remember, bullous pemphigoid had a negative Nikolsky sign. You can't rip the skin off here. But here, since you have necrosis, you can rip the skin off, and it can kill you. High mortality rate. Typically, mucous membranes are involved. Alright, so you can see mucous membranes in image C and D being involved. Targetoid skin lesions may appear as seen in erythema multiforme, usually associated with adverse drug reaction. And there's a bunch of drugs that cause Stevens-Johnson syndrome. We're going to see majority of them in neurology pharmacology, right? Neuropharm, let me just make sure. So when we get to neurology, I don't know if I'll be able to finish the rest of MSK today, but we should be starting neurology pretty soon. And right here, yeah, when you get to neurology pharmacology, you can see all the ones that are highlighted blue like that. Those are all the guys that cause Stevens-Johnson syndrome. Right, so right away, we already have 4 medications here that you really need to know well. Right, carbamazepine, ethosuximide, lamotrigine, and phenytoin. All of them can cause Stevens-Johnson syndrome. So really important to remember that. And when we get to that section, I'll talk about the ways to memorize those side effects, because it takes a lot of time, but I did make up silly little things to memorize that, so we'll see that when we get there. Now, there's another thing. There's the toxic epidermal necrolysis, which is a more severe form of Stevens-Johnson syndrome, just when you thought it couldn't get worse. Right? This one, toxic epidermal necrolysis, this involves more than 30% of the body surface area, whereas Steven Johnson usually involves less than 10%. If you have an involvement between 10 to 30, then it's denoted as SJS10. Alright, so it's a combination of both. Pretty much they're both the same thing. It's just dependent on how much of the body is involved. Okay. Next page starts talking about miscellaneous skin disorders, which again, I feel like NBME loves picking on these guys. Mostly because these are things you can get pictures on, right? You can get a lot of pictures. You can see there's a lot of pictures happening on every page here. And on top of that, step 1 likes it too, but step 1 shies away from pictures and talks more about describing it verbally. So miscellaneous skin disorders, let's take a look. Acanthosis nigricans. This is probably the easiest one, and everyone should know this already, right? The darkening of the axilla and the neck, a sign of basically obesity, insulin resistance, stuff like that, okay? So epidermal hyperplasia causing symmetric hyperpigmented thickening of skin, especially in the axilla or on neck, associated with insulin resistance, which can be related to diabetes, obesity, Cushing syndrome, or polycystic ovarian syndrome. It can also be a sign of visceral malignancy, such as gastric adenocarcinoma, although when we did gastric adenocarcinoma, we saw that the lesser Trellat sign was a bigger deal, right? The lesser Trellat sign was a better sign of gastric adenocarcinoma, but it can be acanthosis nigricans too, so just keep an eye out for that. The next one, really big deal, very high yield, almost every NBME loves asking about this, actinic keratosis. This is a pre-malignant lesion caused by sun exposure. So you get small, rough, erythematous or brownish papules or plaques. There is a risk of squamous cell carcinoma proportional to the degree of epithelial dysplasia. Right? Now earlier in the video before this, we saw seborrheic keratosis, which was benign. Actinic has action because it can lead to squamous cell carcinoma. Right? Seborrheic keratosis, let me see if we can just, I think it was like 3 pages before. Yeah, this thing. Right? This was with Parkinson and Malassezia species. It was weird. Right? Erythematous, well demarcated plaques that you can see around his nasal areas right there. A little over there as well. Areas rich in sebaceous glands, such as the scalp, face, and periocular region. Really not the biggest deal on earth, but you have to treat this with topical antifungals or corticosteroids, and you should be alright. Okay. So going back to where we were. Actinic keratosis, images C and D, so you can see this one here. Again here, it's really not the most evident thing. Like, you can't really tell what's happening just by looking at the picture so easily per se, but just keep in mind, there's that sun exposure part. That's pretty important. The sun exposure part basically means that you have to keep in mind farmers. Right? Farmers are going to be a big deal. So there's a phrase, and let me show you this question from NBME and then we'll talk about it. This question is about actinic keratosis from NBME 21. So it tells you, and see, they gave you a picture too. They tell you a 62-year-old man who is a farmer comes to the physician because of an 8-year history of the lesions indicated by the arrows shown in the photograph. Although there is no itching, he occasionally picks at the lesions, which causes some bleeding. Physical exam shows numerous similar rough plaques on the scalp, face, ears, and forearms. Which of the following is the most likely diagnosis? And then they gave you 8 different answer choices, right? 8 answers. A lot of people wanted to pick basal cell carcinoma. A lot of people thought it was psoriasis because in the question stem, they tell you that there's some bleeding. But it's not psoriasis at all. We've seen psoriasis already, right? There's going to be silvery plaques in psoriasis, and it's going to be more than just in one tiny area where the arrows are pointing. So this was actinic keratosis, right? The students got confused, but you can't. And then there's this phrase right here. The farmer picks carrots. So the farmer word is for sun exposure, which should make you think of squamous cell carcinoma of the skin. And picking carrots is for keratosis, right? It's actinic keratosis. Right? Very often is going to be a question about a guy who is a farmer or some other occupation that involves being in the sun a lot. Erythema nodosum is images E and F, right? So images E and F. This is usually related to something that's a really big deal. Painful, raised inflammatory lesions of the subcutaneous fat, usually on anterior shins, often idiopathic, but can be associated with sarcoidosis, coccidioidosis, histoplasmosis, I mean, we didn't see it with, oh, this is where we saw it, right? We already saw it earlier with Crohn's disease. It can occur with either Crohn or ulcerative colitis, mainly Crohn though. Alright, so erythema nodosum is just your body telling you something's not right. But it's not specific. Seeing erythema nodosum does not tell you what the issue is, but you would have a list of potential differentials you can work with. Lichen planus is pretty high yield. All the P's, right? So pruritic purple, polygonal, planar papules, and plaques are the 6 P's of lichen planus. And you can look at that in G and H, right? So this is kind of purplish, especially in H. Right? G is really hard to tell what this is. You really can't tell what's happening here just because of this picture. But this picture here does kind of help. Mucosal involvement manifests as Wickham's striae, which are reticular white lines, and hypergranulosis, sawtooth infiltrated lymphocytes at the dermal-epidermal junction, and this is often associated with hepatitis C, which is not something that starts with the letter P, so be ready for that, alright? So lichen planus, I always used to think of the C in the word lichen for hepatitis C. Right. In fact, way in the beginning, I used to write this as like hep planus. Right. Like hep. This is supposed to help you remember that. Sure, you would get all the P's down, so you can kind of identify and describe how this looks, and keep in mind that it's related to hepatitis C. Because you can easily get a question where it's just a patient with lichen planus presenting, and then they'll be like, "What would you screen them for? You know, what can you expect them to have?" And you can expect them to have hepatitis C. It's very likely. All right. So like hep planus. Psoriasis rosea is something we talked about in microbiology. So this is a herald patch. You can see it right here. It's all over this person's body over here on the back. This is pretty common, but at the same time not so common on the test. Herald patch followed days later by other scaly erythematous plaques, often seen in a Christmas tree distribution on the trunk. And that's the Christmas tree. The white spots are basically the lighting on a Christmas tree. That's what they're talking about. Multiple pink plaques with collarette scale, self-resolving in 6 to 8 weeks, and really not that significant. And then we all know about sunburn, right? Sunburn, acute cutaneous inflammatory reaction due to excessive UV irradiation, causes DNA mutations inducing apoptosis of keratinocytes. UVB is dominant in sunburns, and UVA is seen with tanning and photoaging. So this is basically a little topic that NBME can pick on, not so much a step 1 thing. Exposure to either one, though, increases the risk of skin cancer. Yeah, I think next week I should be done with the NBMEs I'm trying to get through. I'm going to be doing NBME 20, 21, and 22, where I'm basically going to run through all 200 questions and discuss the explanation for them, as well as show you where in first aid or any other resource they're kind of discussed, all right? And the main goal of that is to kind of do a revision, right? Because that's what NBME is for, a revision of topics and really see how they can present. Because NBME questions are very unlike AMBOSS and UWorld questions. What NBME does is they'll give you minimal information, right? UWorld and AMBOSS, they tend to give you a lot of information. They'll tell you everything about a disease and then hope that you can remember the one other thing. Whereas NBME doesn't tell you shit. They'll just be like, hey, this guy coughed. What's his diagnosis? You know, and then you're just like, fuck, this guy could be coughing from anything. So NBME is really interesting in that manner, and I mean, I'm obviously over-exaggerating it, but it is at that kind of level, and you really have to know your thing. So NBME is a good way to kind of review how things are going to present themselves, right? I'm actually still working on it, too, so I have it open right here, for example. You see? This is NBME 21. I'm up to question number 40 of 200 here, but the others are done. The others are already finished being explained, and I'm gonna be basically telling you what the answer is, and then go to my own notes I'm preparing to kind of help explain how you were supposed to get that right, how you were supposed to know what the wrong answers are, and so on. Okay, so it's gonna be a really good series. I should be getting that started next week for sure. All right, so that was sunburn right here. The last half of this page just talks about burn classification. Not the biggest deal. Most of you guys should already know this pretty well. So you can have a first, second, or third degree burn. The third degree obviously being the worst. A first degree burn is very common, and almost all of us have gone through this at some point. So very superficial, through the epidermis, common sunburn, painful erythematous, and blanching. And the skin usually recovers and starts ripping off, which is very common after any kind of event where you might have been in the sun for a very long time. A second degree burn is the one that has partial thickness burn through the epidermis and the dermis. And this is pretty bad. Right? This can also occur from sunburns. Skin is blistered and usually heals without scarring. Right? So the difference between second and third degree is going to be the scar. A third degree burn is a full thickness burn through the epidermis, dermis, and hypodermis. And by this point, remember way in the beginning someone had asked where are blood vessels found? So it's found in the dermis and hypodermis. So now at this point you've kind of damaged the blood vessels, you've damaged the fat under your skin, a lot of stuff has been damaged. You're going to see painless, waxy or leathery appearance, and it's not blanching anymore because the blood vessel is damaged. The skin will heal eventually, but it will heal with scars. Alright, so that's the main difference between second and third degree. The last thing they talk about here are your skin cancers, and this is a relatively new thing they did, right? With the upper lip being the letter B and the lower lip being the letter S. This is a 2019 thing. So basal cell carcinoma, more common on the upper lip and the forehead, above the lips basically. Squamous cell carcinoma is usually a thing below the lips. It can be seen on, I try to remember if I've ever seen the squamous cell carcinoma question above the lip, but I'm not sure. But the fact that they did this usually really indicates that this must have been a very solid difference between the two. So let's take a look at that, right? Basal cell carcinoma. Most common skin cancer. Found in the sun-exposed areas of the body, such as the face. Locally invasive, but rarely metastasizes. You're going to see a waxy pink pearly nodule. Commonly with telangiectasias and rolled borders and central crusting or ulceration. This entire sentence of describing it is extremely critical. You're going to get so many questions where they'll be like, oh, you know, they'll tell you a bunch of unnecessary, useless information, and then there'll be that one tiny half a sentence. They'll be like, oh, it's waxy, pink, and pearly with some rolled borders, right? And that's a giveaway for basal cell carcinoma, and this is what they're talking about. So clearly this is very waxy, this is pearly, and it is rolling, right? The borders are kind of like turning into itself, and central ulceration or crusting is seen. And you see how this is above the lip, right? So that's what they're talking about, the basal cell carcinoma above the lip, not below the lip, right? And image B and C and D are also related. So basal cell carcinoma also appears as non-healing ulcers with an infiltrating growth. And we saw that in microbiology, not microbiology, sorry, in biochemistry. In biochemistry, we saw this because remember when we were in let me go back to that. Because cancer is always related to biochemistry and messing up some kind of like genetics thing. So let me see. Where did they? I think it was right here. Yeah, right here. See? I had a picture here that I put this picture here because this was for nucleotide excision repair, right? Defective in xeroderma pigmentosum, because you're going to have the inability to repair DNA pyrimidine dimers, which can be due to UV exposure, hence basal cell carcinoma. Right, so you want to make sure you kind of remember this stuff, right? The ulceration that's occurring on the nose, very important thing, right? So ulcers with infiltrating growth or as a scaling plaque, right? So that's image C, right? A superficial scaling plaque. C is probably the least likely thing that you'll look at and be like, oh yeah, that's cancer. So that's a very, useless picture. I hope they don't give you that picture on your step one, because if you see the image C out of context, just anywhere, the first thing you think of is not cancer here. So that's pretty important. Whereas with A, you definitely think of cancer. B, you could. The other image that I showed you on the previous page for B was a lot better. And D is a histological image where you can see there's some kind of weird disruption happening here. So basal cell carcinoma, they tell you basal cell tumors have palisading nuclei. This is a very big keyword, palisading nuclei. Palisading usually means fencing. When you put fences up, that's what they're talking about with the word palisade. Can't exactly see the palisading nuclei they're talking about here per se. I mean, I know they're trying to make you focus on this, so this is like a fence around all of these cells. You should definitely look up more images for palisading nuclei. Let me see if I found something really good really quickly. Palisading nuclei. But I have seen it in one of the NBMEs. I can't remember if it was 2021 or 22. But I have seen like them talking about that word. They do phrase that. So in all of these, you could see something similar. This is most similar to the image they just gave us, right? Basal cell carcinoma. This is your palisading nuclei. So what palisading means is putting up a fence, right? So that's what they're talking about. This is the fence around this. This is a cartoon image describing you. Nuclear palisade. You can see this is a fence, right? These are clearly very much like a fence outside the house that you would put up. But this is just a cartoon drawing. If you were to look at it under real stuff, so this image most mimics what's in this cartoon. Right? So you have your nuclear palisading, a fence. Right? Palisading nuclei, you always want to think of a fence. If you see something that's fencing around in a histological image, you think of basal cell carcinoma. Right? This one being the best image for basal cell carcinoma. Pathology outlines. Pathology outlines is actually a really good website to really get more information on anything that you might need. I've used a lot of their resources, and then they have really good images. They have really good gross images as well as histological images. You can see right here, microscopic stuff. So they're perfect. Pathology Outlines is a great website for that stuff. That's kind of where I get a lot of my information for this book. Okay, so that was basal cell carcinoma. That was the basal. That's the B up here for your upper lip or above the lip. The other guy is your squamous cell carcinoma. Right? This is the second most common skin disorder, or sorry, skin cancer. Images J, K, and L. Okay, so let's take a look. Associated with excessive exposure to sunlight, just like basal cell carcinoma, as well as immunosuppression, chronic non-healing wounds, and occasionally arsenic exposure. Commonly appears on the face, as you can see in image J. Now this is looking very different from image B, right? So you can see this is also above, right? It's above the lip, it's on the nose right here, but very different from what's happening in B. Lower lip, which is image K. And remember the other thing we just saw that looked a lot like this? The pyoderma granulosum or something, which occurs in pregnant women, right? This is very similar to that, visually. In terms of an image, it looks just like that. Where is it? Sorry, not pyoderma, pyogenic granuloma, right? Image D. You see the pyogenic granuloma? Except remember that this thing can ulcerate and bleed. It can just pop open by itself. Whereas what we're looking at now, this is not going to ulcerate and bleed. This is just cancerous. Alright, this is not going to ulcerate and bleed. This is just cancerous. But very similar kind of, in fact, it's funny how both of those pictures have it in the exact same area too. Alright, so keep that in mind. And then lower lip, ears, and hands. Locally invasive, may spread to lymph nodes, which is a difference from basal cell carcinoma. It doesn't metastasize much, right? And will rarely metastasize. Ulcerative red lesions. Histopathology is a very big deal. They always talk about these keratin pearls, and they also mention another thing called intracellular bridging, right? Keratin pearls and intracellular bridging. We talked a lot about that when we were looking at squamous cell carcinoma and GIT. We're going to talk more about it when we get to squamous cell carcinoma and other organs. So just be ready for that. Keratin pearls. Keratin pearls are a giveaway for squamous cell carcinoma. And that's what they're trying to show you here. I wouldn't say that's such a good picture for keratin pearls. Keratin pearls. Keratin pearls. So keratin pearls usually do actually look like a pearl. So you can see this is the most common picture I've seen for keratin pearls. Alright, this is another one. Alright, so keratin pearls, they're just they're very similar to another thing that we've seen that has pearling. It's found in meningiomas and all of that. I forgot what that was. The word is skipping me. But just make sure you don't confuse it too, right? Because this one especially can really come off as the other thing that has the circles on histology. What was that? It's found in meningioma. It's found in a certain kind of thyroid cancer too. But the word is escaping me. Either way, keratin pearls and intracellular bridging. They also use that too. See, intracellular bridges. So intercellular bridges are a little harder to see, but if you have keratin pearls, there's usually a bridging in between the pearls too. What are they pointing at here? Yeah, this is a tiny bridge right here, actually. See? A connection that's like a tiny, skinny connection between two cells. It's very rare. You never see that in like normal histological images. If you get like a normal histological image, or if you get any other histological image that isn't about squamous cell carcinoma, just take a good look at the picture. You won't see any intracellular bridging happening. It's not a thing. Very rare for that to actually happen. Actinic keratosis, which we talked about earlier, right? The farmer and the carrots. Actinic keratosis is a scaly plaque and is a precursor to squamous cell carcinoma. So now what are the other things here? So in the middle right here, keratoacanthoma, image E. Right? Keratoacanthoma. Samoma bodies, thank you. Yeah. Keratin pearls can look a lot like samoma bodies. So just be careful with that, because depending on the staining and depending on the slide they use, they can really try to confuse you, especially if the question stem itself is talking about things that are relevant to a samoma body. Make sure you don't get confused by a keratin pearl and think it's a samoma body. Don't fall for that. Step 1 loves doing this thing called baiting you into an answer, so don't get baited. Thanks a lot. Alright, so keratoacanthoma, seen in middle-aged and elderly individuals, rapidly growing, resembles squamous cell carcinoma, presents as dome-shaped nodules with keratin-filled centers, grows rapidly, and then may spontaneously regress. So again, very low-yield topic. It's not the biggest deal. It looks weird too. It looks like, it ruptured and it was just kind of full of potato or something. It's not looking like any of these other guys either. Right? So let me try to zoom in. So if you look at this image, you see, you can find more pictures as well for keratoacanthoma, and they all kind of have this thing happening. It ruptured, but it's full of crusty brown stuff, and it's not bleeding. Right, so every little detail is very important. It's not bleeding. It's not on the lip. It ruptured. It's full of brown crusty stuff, and that's generally it. It's going to get bigger, and then it'll go away. Just like our strawberry hemangioma, right? The strawberry hemangioma on the infant, it's going to get bigger, and then it's going to go away. Spontaneously regress. The biggest thing on this page is your melanoma, right? Very important skin cancer, very dangerous skin cancer, and it metastasizes like crazy, unlike the squamous cell and basal cell carcinoma. So this is a common tumor with significant risk of metastasis. There is a S100 tumor marker. The S100 stuff was, remember, for neural crest derivatives. Associated with sunlight exposure and dysplastic nevi, fair-skinned people, basically Caucasians and white people, are at increased risk compared to African and black-skinned people in general. Depth of tumor, which is your breast lobe thickness, correlates with the risk of metastasis. Look for your ABCDEs, which everyone should know by this point. So if this melanoma thing, if it's asymmetric, the borders are irregular, the color is varying, some parts might be darker than the other, and the diameter is bigger than a coin, more than 6 millimeters, as well as there's evolution over time. All of these are pretty much giveaways for melanoma. So you can see in both of these images, right, this is at the heel of this man's foot, and this is on this man's face. So you can see that the lesion itself is really big. It's this entire thing over here. Some parts are darker than others. Right? It's not regularly circular, and nor does it have regular borders. Same thing here. Right? It's not perfectly symmetric. It doesn't have regular borders. It does look like this one portion in the middle is less dark than the others. Right? So, and it's probably going to be showing evolution over time. It's going to get bigger and weirder. Right, so very crazy stuff. F over here showing you also same thing. Right, it's big. Half of it is darker than the other. Irregular borders. Alright, so very important to watch out for that. And then the least common one is nodular. I've almost never seen the nodular one. This is also a melanoma. The reason you can always pick these out, by the way, that it's a melanoma and not some kind of nodule like the other stuff we looked at, is because compared to all other nodules like this one, even this thing here, this is going to have some pigmentation to it. Alright? It's going to have some pigmentation to it. It's going to be pretty big. This is almost 2 centimeters in width. And these black portions in between, they could be a little bit of bleeding that froze over, but it's really just melanin. Alright? So it is a melanoma. So that's what they're telling you, right? Including superficial spreading, nodular, lentigo maligna, and acrolentiginous, which is the highest prevalence in African American. Acrolentiginous, the eye. Right? This one is occurring on the more white surface of this black person's body, right? So the sole of the foot, the palm of the hand, that's the most common stuff for black people. Mainly African Americans, but also Asians apparently, but I don't know the association here or how significant that is. Often driven by activating mutations in BRAF kinase. And you have to know about BRAF kinase. Primary treatment is excision with appropriately wide margins. You excise the whole thing, but you cut out bigger than just that area. Metastatic or unresectable melanoma in patients with BRAF V600E mutation may benefit from vemurafenib. Vemurafenib is a BRAF kinase inhibitor that can help those people, right? And this thing itself also means something. I think it was the RAF is for BRAF, right? What did the rest? And then IB is for inhibitor, but there was more to it too. I think. Oh, and then the V and the E for reminding you V600E, right? So it starts with the V and E right here. That is to remind you the V600E. RAF for the BRAF kinase, and it's IB at the end because it's an inhibitor. So something like that. And we're going to see that again when we get to the actual medication later on in the pharmacology section. And that's generally it, right? So this here is a URL picture showing you melanoma depth and invasion, right? There are the Clark levels and the Breslow depth, right? So obviously number 5 being the worst is actually reached the subcutaneous fat, right? But things start getting really bad after number 3, right? After number 3, where you already started piercing in past the dermal epidermal junction, this is starting to now get to a point where it's going to become very metastatic. Okay, and that's it. That's the end of dermatology. So make sure you review, make sure you go through more pictures, and use today as a good chance to go through some microbiology with this page. All right, make sure if you don't remember something about some of these bugs, go back and review that. And then in the next video, we'll go into musculoskeletal pharmacology, which is a really important one because this is where they talk about your arachidonic acid derivatives. All right, so NSAIDs and NSAID related stuff is going to play a big role here, and it's very high yield. So don't miss that video. And thanks a lot for joining.